Good evening, all the aspirants present here. Good evening, sir. So, the topic for today is Station 1. It is respiratory. And the speaker that we have here is Dr. Chinmay Maity, sir. He is a senior consultant and general and geriatric medicine. So, sir, you can unmute your mic and we'll be starting. You can start. You can take over. Thank you. You can start.
Now, can you hear me?
Yes, sir. Aspirants, this is going to be an interactive session as it is MRCP PACES. So all the aspirants are required to kindly unmute their mic whenever it's required. Thank you, sir.
Okay, thank you. So, good evening, everyone. Hello. Hello.
Good evening, sir. Good evening, sir.
Good evening, sir.
Yeah, okay. Welcome you all to today's session on respiratory examination. So, I'm going to discuss today. You know, it's a huge thing. In one session, it's not possible to complete body, but I will stress mainly on the basic anatomy, physiology, and the way, the process of examining, how to do it, and direct case examinations will be at the end. But I think this probably hands-on will be better. But anyway, whenever you want to ask a question, actually you can pause me and call me that and ask me the question. So actually, we know our today's topic is respiratory examination, but before any systemic examination, we must have a general examination at a glance, because if it is a very sort of short case, then it will be very brief. Then it is a sort of semi-long case type things, then it will be little more in details. So you know the stations and where which cases are done. So I'm briefly discussing on what are the general things we have to have a look before going into the proper systemic examination. So general examination, there should be a very quick visual survey of the patient, and as you know, this is PACES. That means the practical examination session. So theory will be there a little bit, but not much. But so visual survey, that means when you are actually confronting the patient for the first time, how you see the patient, the appearance and attitude of the patient, that's very important at your first sight. Whether the patient is calm and quiet, or whether the patient is unkempt, restless, or patient is cachectic or obese, sort of thing. The very first look. So most of the time, it may be the patient is comfortable and alert, that sort of thing. Then anemia, cyanosis, jaundice, clouding, edema, maybe neck veins, lymph nodes, and the pulse, blood pressure, respiration, saturation, and maybe in blood glucose level. So this is a very basic general thing to be completed. Most of them in the real life situation, you will see the pulse, blood pressure, respiration, saturation, and CBG done by the nurses. So when you are seeing a patient in the A&E or maybe in the outdoor, many of these things are done by the nurse assistant. But when you are seeing the patient on your own, this must be included in the general examination. Now we are coming to the respiratory examination, the basic anatomy, then basic physiology, the cardinal symptoms and signs, then a bit of surface marking of the lung, and then we will go into the examination proper. So we must have a very good understanding of the basic anatomy and physiology of our respiratory system, which we are going to discuss today. Can you hear me?
Yes, sir.
Okay. Now we are coming into the basic anatomy of the respiratory system. We have an upper respiratory system, that is the nose, nasal septum, paranasal sinuses, nasopharynx up to the end of the larynx. And then lower respiratory tract starts from the beginning of the trachea, then two main bronchus, then bronchioles up to the alveoli. You all know that the when the bronchuses are branching, so there are the trachea is the zero generation, the main bronchus is the first generation of tracheobronchial tree. Then comes the segmental bronchus, that's the third generation, second generation. That's how it goes on, and up to the terminal bronchiole, which is about 16th generation, and this terminal bronchiole is the last one of the conducting zone. That means it has got a cartilage in the wall. After that, it comes the respiratory bronchiole, which does not have any cartilage. And so from respiratory bronchiole, which is about 4 to 5 generations of respiratory bronchioles are there, and then alveolar duct, and then alveoli, which is called the terminal or last generation, that is 23rd generation. So trachea is the zero generation, then main bronchus, two main bronchus is the first generation, and alveoli are the 23rd generation. It as if like a tree, the stem is zero generation, first branch is your first generation, and then the leaves at the end, leaves are the 23rd generation. So basically conducting zone up to terminal bronchiole, which is the 16th generation, and then from 17th to 23rd generation where the actual gas exchange takes place. So that's the respiratory zone. Then we must know the segmental bronchi. In the right side and the left side, right side there are 10, and the left side there are 9 segmental bronchi. And this is very important to know the lung segments. So right upper lobe bronchus, that divides into 3 apical, anterior and posterior segment. Then the right middle lobe bronchus, it is divided into lateral and medial segments. Then the right lower lobe bronchus, it's apical, anterior, posterior, lateral and medial segments. This medial one is missing on the left side. So apical, anterior, posterior, lateral in the left side, lower lobe, and the left upper lobe bronchus divides into 2, the upper lobe and lingular lobe. So lingular one is superior and inferior, and upper lobe is similar to right upper lobe, apical, anterior and posterior segment. So this you must know that there are these 10 in the right and 9 in the left lung segments. Then the basic anatomy continues. After the respiratory tract, then comes the bony chest cage. The bony chest cage it consists of 12 thoracic vertebrae in the back, then 12 pair of ribs and costal cartilages, and the sternum in the front. Then comes the respiratory muscles. So respiratory muscles, the normal respiratory muscles are external and internal intercostal muscles, which raises the ribs on both sides like a bucket handle fashion, and the diaphragm in the below, which moves like a piston up and down. Then the accessory muscles are allinajai, sternocleidomastoids, pectoralis, serratus anterior, trapezium, and scalene. So these are the muscles we may see working when the patient is in respiratory distress. Otherwise, normally they do not work. Then the respiratory nerves, very important, the phrenic nerve, which is formed from C3 to C5 segment, which supply the diaphragm. So if there is phrenic nerve injury, there may be diaphragmatic palsy, and which can lead to shortness of breath. Then the intercostal nerves are coming from the ventral rami of T1 to T11 segments, which supply the intercostal muscles, the motor part, and then the sensory part supplies the overlying skin as well as the underlying parietal pleura. We also have other three nerves which are responsible for control of airway reflexes like cough reflexes. This is the vagus nerve, the glossopharyngeal nerve, and trigeminal nerve. Now comes the higher control. The higher control, that is the respiratory center, is situated mainly in medulla and partly in the pons, which is responsible for the autonomic control of breathing. It's like the cardiac pacemaker sinus node. We actually, our respiratory drive comes from medulla. And this is the autonomic part of the respiratory system. But as you know that in the respiratory system we have some voluntary control, because we can hold the breath, we can take deep breaths, we can hyperventilate, we can stop ventilation for a while. So this is the control which is the voluntary control. This voluntary control comes from cerebral cortex. So this is the basic anatomy we discussed: the respiratory tract, the bony chest cage, the respiratory muscles, the respiratory nerves, and the higher control. So a problem anywhere in this system can lead to breathing problem.